My name is Benjamin Greenberg. I direct the Transversemyelitis and Neuromyelitis Optica program here at UT and at Children's here in Dallas. And this is our third time playing host to the Rare Neuro-Immunologic Disorder Symposium, which is sponsored by the Transversemyelitis Association in partnership with us here at UT and Children's and the TM program from Johns Hopkins in Baltimore. Just by a show of hands, just to get a sense, how many people here is this their first symposium going to? Outstanding. Doug, put your hand down. So that is great to have you here. How many people here are from outside of Texas? So you had to show a passport on the way in. All right, got it. We'll do it, I can't go state by state, but East Coast, so if you're in the Eastern time zone. That's not a state. And it's not. It's a state of mind. And I will note, they all sat together, okay? So they're all over there. Central time, anyone in this time zone? Okay. Mountain time, you guys are the cool people, all right? Pacific, so we got the other coast. Anyone from outside the United States? Here, okay. Great, well, welcome. If I welcome you in Texan, it's welcome y'all. We're excited to have you all here and to, as I said, have a jam-packed day. The point of Symposium is multiple. The points of Symposium are multiple. The first is education, but it is a three-way education. We have a group of clinicians, scientists, providers here who are hoping to impart some knowledge and understanding to you from our perspective. We are hoping to gain understanding and knowledge from you, so the education is bidirectional. And the third is amongst yourselves. It is extremely important for individuals who have been affected by these rare conditions to spend time with each other because you learn from each other. In fact, most of my patients will say from this experience that they learn just as much, if not more, from their community than from myself or any member of the healthcare team. The second reason Symposium is critically important is for some of you in the room, it may be the first time that you meet somebody else who has the same condition. It's definitely probably the one time in the year, if not every other year, where you can say I was in a room with 100 people who knew the language and had been through similar things. In your day-to-day lives, if you are going to your doctor's office or checking out at the store and say I have transverse myelitis or neuromyelitis optica or ADEM, people pause and either say, what's that? Or I'm sorry to hear it, and walk away because they fear they're going to catch something. So it's a different experience to be in a room where the community has had that shared experience, and I hope it will be a benefit and helpful and a good experience for everyone. In holding true to our fashion for the symposium, we're already a little late, but that's fine. The time limits in the agenda we always view as optional. And we try to stick to it, but we've not been successful in over a decade, so I don't have hopes today. The format for today is different than what we've done in other years. In other years, we've done this over 2 days, and we got feedback from folks that it's a lot in any given day over 2 days. But there were certain parts of Symposium that we consistently got feedback that people really enjoyed, specifically having the opportunity to do question and answer sessions and the opportunity to do breakout sessions. So the way we structured today was to shorten the didactic session, meaning to shorten the talks, the formal presentations with slides that we're going to have in the morning. They are there to set the groundwork, to give you an overview of the different topics that each speaker will discuss. But then we move towards two different panel discussions. One is a preset panel discussion. The second is a question and answer session, which is going to be moderated by Dr. Alan DeSena from Cincinnati. And for the question and answer session, there are two ways to have your questions addressed. So one is during the session, just raise your hand, shout it out, and we'll do our best to answer it. The second is you should have paper and pen at your desk while speakers are talking, if there is a question you want addressed, you can write it down, and you can even indicate if you want to direct it to an individual person or to the whole panel. If you leave them at the front desk during the break session, Dr. DeSena will be going through them and putting them together for his portion of the question and answer. So if you don't feel like you want to raise your hand and publicly ask the question, feel free to write it down, and we will try and get to all the questions we can. The breakout sessions in the afternoon are all spectacular. That's the good news. The bad news is you can really only go to 2 out of the 4. So you have to look at those and prioritize which 2 you want, and then you can go in either order because it'll be the same folks doing the sessions each time and the same predetermined content. So as you look through those 4 over lunch today and over your breaks, try and decide what would be most useful to you. So with that in mind as a backdrop, it's important to understand how we got here and give thanks to some individuals. So the first is the sponsors and the organizers, starting with the organizers, the Transversemyelitis Association. So every year that we do Symposium in October, somewhere around July and August, the group that puts it together starts saying, what were we thinking? And sometimes there's a little profanity about whose idea it was this time to do it. There are some awkward email exchanges because there's a tremendous amount of work that goes into bringing everybody together. And the Transversemyelitis Association, under the direction of Chitra Krishnan and Sandy Siegel, with help from an incredible staff, Gigi, Rebecca, Roberta, do an incredible job to put together a symposium, a structure, and a community event to bring you all together. So my hat's off to the TMA for doing this yet again this year. And to be clear, while I lead the TM and NMO programs here at UT Southwestern, I have done little to nothing to get you anything in terms of organization for today. I have to give all the thanks to the team that works with me and suffers me on a regular basis. This year, the efforts were led by Sam Hughes and his group. So again, I just have to say thanks to them for everything they did. I was actually renting you all the little handheld scooters and Segways to get from the hotel to here, and he said, no, we should get a shuttle. So, you know, that's all due to him. We wouldn't be here if it wasn't for several groups in the community, both private and public, who stepped up to sponsor. They are listed in packets, and so sponsors listed here, and we have representatives in the audience. These are companies, public and private, an institution, Kennedy Krieger, the spinal cord group at Kennedy Krieger, who not only just wrote a check to support things, but many of them have representatives here to interact with you and us, and we could not do this without their help. So I am most appreciative for them making an investment in a rare disease community with no restrictions. So there were no restrictions put on the use of the funds. These were unrestricted grants and gifts on your behalf to bring people together. So I'm most appreciative of those efforts. So with the remaining time, what I was supposed to do today, besides welcoming you, is to give you an update about what we were doing yesterday. And what I mean by that is we brought in a group of clinicians and scientists, people with diverse backgrounds, from neurologists who treat patients, both adult and pediatric patients with these rare diseases, to MRI experts, radiology experts, interventional radiologists, people who do angiograms, scientists who look at the molecular basis of these diseases. And we put everybody in a room. We had some people on the phone from France, some people on the phone from India, and this far-off place called Arizona, to get together in what was called the 2015 International Myelitis Working Group. And the reason for it was it's been over 13 years since the last formal diagnostic criteria for transverse myelitis came out. And if we turn back the clock, that criteria came out before we had identified the aquaporin-4 antibody that's associated with neuromyelitis optica. It came out before there was a recognition of acute flaccid myelitis, a variant of transverse myelitis. It came out before there were any treatment guidelines published for transverse myelitis. So it was time for us to revisit the diagnostic criteria, because these criteria get used by clinicians all across the country when patients present with signs or symptoms, and they are the Bible, if you will, of what should clinicians be doing. And so it was time to update it, and we brought together groups from a wide array of institutions from across the country. And if I left off an institution, please let me know. It was fun to get everybody together, but it was also fascinating to hear about everybody's experiences and the different approaches. Our colleagues from the UK, from Guy's and St. Thomas and the Walton Center, had unique perspectives that we don't necessarily see on a day-to-day basis here in the United States. But it was a great way for us to find common ground on how to approach these issues. So the nomenclature, the words that are used to describe these conditions and this condition, what's been called transverse myelitis, is atrocious. How many people here, if you're willing to share, about you or a loved one, were told they had transverse myelitis at some point? And how many people here had that changed at some point to a different condition? And somebody said, well, it could be MS, but it's not MS. It might be neuromyelitis optica, but it's not. You had idiopathic transverse myelitis, which means I'm an idiot. I don't know what it is. So these terms, and what's listed here is if you go to the literature. So if a clinician goes to the journals, the medical journals, to look this up, all of these different terms are used to describe very overlapping syndromes. So if you're a physician in a practice that will see one myelitis patient in your career, and you go to the literature, it is a disaster to try and find what is being described. And the problem is, or the challenge is, that we lump everything in the spinal cord together, but there are very distinct differences in what each of you experienced if you have had spinal cord events. And the differences are based on really two things. The first is within the spinal cord, and this is a picture of a spinal cord within the spine, how big a lesion occurred, how big an area was affected. Was it the size of a quarter, or was it as long as 3 to 6 inches? Was it half a spinal cord or whole spinal cord? So in general, we separate these things out into short or long lesions, because that's how scientific we are. Was it short or long? And so if your lesion went for more than 3 vertebral bodies, these bones are vertebral bodies, if it went extended over more than 3 segments, you're in the long category. If it's less than 3 segments, you're in the short category. And it turns out that's important. There are different conditions that give long lesions than that give short lesions. So it's important for clinicians to separate out those. The next thing that's important, which is something that we have really only begun to push, is what part of the spinal cord from front to back, side to side was affected. And I know it's really early on a Saturday morning, but I'm going to give you a quick anatomy lesson because a lot of what is talked about today and a lot of your questions will be based on what part of your spinal cords, if they have been affected, what parts were. And the important thing to recognize is when you want to move your muscles, the way you achieve it is by sending signals through 2 wires. So you have a brain that says, I want to wiggle my thumb, my right thumb. Your brain generates an electrical signal which travels down wire number 1, traveling down the spinal cord to whatever level it has to get to, where it will connect within the spinal cord to wire number 2, which lives in the center. That second wire leaves the spinal cord, comes out of the spinal cord, and actually goes to your muscle. So the electrical signal goes through wire number 1, connects to wire number 2 within the cord, and then wire number 2 goes out to the muscle. Why pre-8:30 in the morning, you haven't even finished your first cup of coffee, am I telling you this? This forms the basis for what pattern of deficit a patient has when their spinal cord is affected. How many people here, for yourself or your loved one, at some point during the diagnosis were told this might be Guillain-Barré? So this is almost half of the hands. Okay, why is it so hard? Why does that keep coming up as a misdiagnosis in transverse myelitis? The reason is Guillain-Barré is a disease that affects wire number 2, and wire number 2 only. It doesn't affect the spinal cord directly. So if you have a spinal cord issue that's affecting the first 5 millimeters of wire number 2 before it exits the spinal cord, it can look like Guillain-Barré. And clinicians forget that wire number 2 begins in the spinal cord. So you can have a myelitis, you can have a spinal cord issue giving you a syndrome that looks like Guillain-Barré, but they get managed differently, they get treated differently, and the long-term issues in the workup are different. So in the working group yesterday, we spent a lot of time discussing the difference between spinal cord disorders that affect wire number 1, which is in the white matter off to the sides, or wire number 2 in the gray matter. And so for some people in the room, you had something that affected just wire number 1, and that was it. For some of you, you had something that affected wire number 2. How many people here over the summer last year heard about this acute flaccid myelitis or acute flaccid paralysis? So what happened in that, and we're going to have a whole talk by one of the world's experts on it, Dr. Schreiner. What happened there was, for the first time in aggregate, we saw a lot of mainly children having inflammation in the cord or a problem in the cord that affected almost exclusively wire number 2. Didn't do nearly as much damage to wire number 1. And that was a unique pattern to be seen that is different than a lot of myelitis patients. So the reason I'm telling you all this is we had to work through yesterday, begin the process of working through, what are we going to call this? How are we going to make it easy for clinicians when they are faced with a patient who has a spinal cord problem to navigate the world of spinal cord problems so they can get each of you plugged in, not just with the right therapy in an emergency room, but with the right approach to rehabilitation. If you're somebody who has a wire number 1 problem, your approach to recovery is different. If you're a person with a wire number 2 problem, your approach to recovery is different. So we have to make sure we give people the right diagnoses in order to give the right therapies. So we started with this term transverse myelitis. I really am not a fan of the term. And let me tell you why. Myelitis, by definition, means inflammation in the spinal cord. That's all it means. So if your immune system enters the spinal cord for any reason, right or wrong, it could be there to fight an infection or it could be there by mistake, that is myelitis. It's inflammation in the cord. The term transverse got used over 50 years ago in an attempt to describe one of the symptoms that people have, which was referred to as a sensory level, where people would walk in and say, Dr. Greenberg, from here down, things don't feel normal. So that transverse was that line where people could say above it, things feel fine, I can feel things. Below it, not so much. So the term transverse myelitis stuck. The transverse stuck with myelitis. But unfortunately, it morphed into a world of great confusion where you can have transverse myelitis as part of multiple sclerosis, transverse myelitis as part of NMO, or transverse myelitis just as its own entity. And what we are looking to do is to clean that up. And what we started with yesterday was these concentric rings. And the largest ring is this term myelopathy. So myelitis means inflammation in the cord. Myelopathy just means there's something wrong with your spinal cord. I don't know what it is. You could have fallen off a motorcycle on I-30 today and smashed into a guardrail and develop a myelopathy from the trauma of hitting your spinal cord. You could have an infection in a cord. You could have a lack of blood supply to a spinal cord. You could have a tumor in a spinal cord. You can have a lot of things that give you a myelopathy, that damage to the cord. Only some people with myelopathy have myelitis. Does that make sense? There are many people who have lived their lives with the diagnosis of transverse myelitis only to find later that there was an alternate explanation of the myelopathy. It happens. And what we did is we brought in experts from around the country to discuss what are some of the most common mimics of transverse myelitis? What are some of the things that I would look at the MRI and the spinal fluid, and Doug Kerr would look at the MRI and the spinal fluid, and we would swear that this looks like transverse myelitis? only to rarely sometimes find that there's an alternate explanation. So we spent time trying to discuss what were the red flags. How could we get smarter as a community of practitioners to counsel you on when are things not adding up and when should we look for an alternate cause of your myelopathy. And the working group is meant to put that on paper so that we can guide other clinicians. So I'm not going to go through this in detail. I just wanted to give you a little history on the diagnostic criteria. This goes back close to 100 years, actually, but the first formal papers are from the 1960s, where people started saying, well, how are we going to put people into different categories? We didn't have MRI in 1960s, so everything was just done clinically and based on Gestalt. It wasn't until we got really into the 1980s and 1990s, for sure, that we started using imaging. And when we got to the 2002 diagnostic criteria, which was the last time this was developed, a list of criteria were put together. And you don't have to read everything here. The point of this slide is to show you that there was what was called an inclusion criteria and an exclusion criteria. The notion of, we go through a checklist. Do you have this, 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 and this? And do you not have any of these red flags? And if you met that criteria, we would say you have idiopathic transverse myelitis, meaning there was inflammation in your spinal cord and we don't know why. This criteria both missed people and it put some people into the transverse myelitis category who didn't have it. It's an excellent criteria and it's worked very well for a decade, but with what we've learned over the last 5 to 8 years, it was time for an update. What came out of that criteria, and again, it's small enough to discourage you from trying to read it, was this algorithm. This is literally a page that a clinician in a pediatrician's office or an internist's office or an emergency room can flip to if somebody walks in with signs of spinal cord problems to help guide them on what they should be doing and thinking about when diagnosing a patient. Unfortunately, it turns out a lot of people haven't read it over the last 13 years because we still have people showing up to internist's office, pediatrician's office, and emergency rooms with clear signs of spinal cord dysfunction, only to be sent home being told it's a pinched nerve. That's my favorite. Second favorite is stress. I'm not sure how many people here have experienced this. So this is always fun. By a show of hands, you or your loved one, from the moment you had clear symptoms, and you get to define that, of something was wrong with your spinal cord, for how many people was it more than, did you have to go to a clinician more than once before there was a suggestion it was spinal cord? So almost everybody, okay. So that's the norm. Some situations are harder to tell than others, and admittedly so. So there are some times where I wouldn't have caught it in the first day, and I think everything's a spinal cord. And then there are times, people come in demented. I say, it could be your spinal cord. And actually, I don't know if our neuropsychologists are here, but it turns out it might be your spinal cord, but that's another story. But then there are times where there are just egregious misses to tell a 15-year-old boy who hasn't urinated in 24 hours and needs a Foley catheter to empty the bladder that it's stress. I haven't met a 15-year-old boy who will let you put a catheter in their bladder for stress. They jump off the table and say, I can pee, it's fine, and sent out of the ER. Those are the more egregious situations where we as a group yesterday spent a reasonable amount of time discussing that coming up with this criteria is not enough. Once it's done, and once the new version of this algorithm, this Bible, if you will, of an approach to a spinal cord patient is done, it is up to us. The onus is on us. And when I say us, I mean all of us, not just the clinicians, not just the Transverse Myelitis Association, but you as ambassadors and advocates for a community you never wanted to be part of, but now you are, to help educate and raise awareness about this. What we want to get to is a world where clinicians on the front line are aware about these conditions. And what I always say is, I do not need ER physicians to be able to even spell myelitis. That's not their job. Their job is to be able to find out, is this a spinal cord problem or not, and what's the first step in management for it, and then get a neurologist or somebody who can take it from there on board. So this is about raising an awareness, not just about myelitis, but about all spinal cord pathology, because you are part of that larger myelopathy community. And so as you talk to members of the TMA, support group leaders, advocates, I encourage everyone here to get involved in that mission on how do we raise awareness about these conditions. So I put a picture here of where we've come to in terms of MRI, and just to give you a sense, I'll start here. These are a series of pictures from different patients. This is a spinal cord kind of cut across the middle. This is if we cut you the long way, and this dark gray is the spinal cord, and in each of these you can see some white mixed in with the gray. That's the MRI telling us there's something wrong. And what's evolved over this last decade is we've started to recognize and separate out these patterns, where sometimes those white dots are right on wire number 2. And sometimes those white dots here and here are only affecting wire number 1. And sometimes they're affecting both. So we spent a lot of time yesterday going through these different patterns and trying to make sense of the madness, sense of the chaos, and give clinicians in the field a way to approach this so they can then walk into your room, a loved one's room, or the rooms of patients who have yet to come to our clinics or hospitals and have better advice, better educated guesses on what will happen prognostically and what should be done therapeutically. Therapeutics in recovery start with getting the diagnosis correct. And so unless we have the diagnosis correct in that first 24 hours or the first 24 years, it's hard to tell people how to recover and how to improve. As we move into the age of restorative therapies, therapies that will fix the damage that's been done, for those of you in the world who have wire number 1 affected, you need a certain type of restorative therapy. It probably won't help people who have wire number 2 affected. You're going to need a different. So we have to get the diagnosis correct, the classification correct, or we will not be able to offer people the advantages that come with the technology that's being developed. So we have a plan. The first is, and I'm going to brave jumping into this. We had a long conversation yesterday, and I'll do a straw poll. I don't know if Dan Becker's in the room. So I'm gonna ask the question that you asked yesterday. As a group, when publishing a criteria, we have to give it a title. And we, from a preliminary perspective, are discussing dropping the term transverse and referring to all of this as myelitis. And one of the concerns that was raised was, from a patient and family perspective, are we just going to make this even more confusing? Because we've been living with an identity as transverse myelitis for a long time. And as we move to, well, I have myelitis, and this is the subtype, if the effort is a help, but it is a psychological and identity change, is that something people feel bad about or wrong about or caution us against? And you don't have to say now. You can put it in the question and answer session. But we as a group decided to focus this on myelitis and not calling it transverse myelitis, so we can bring some order to the chaos that exists in the community. We're going to organize and identify the subtypes. We're going to give our recommendations for testings, and we're going to give very clear statements about not just what therapies should be considered, but when. Because we firmly believe a delay in therapy is a bad idea, and so we want to give the greater community guidance on when should they be pulling the trigger on different therapeutic interventions, and not just at the acute setting, not in the first 24 hours or 7 days, but when you're a year out. What are the therapeutic options that should be considered? Because therapy doesn't end in the first week or first 2 weeks or first year or first 2 years. There is not a magic number where the door closes where recovery can't occur. We have patients in our clinic who are more than 10 years out who are still recovering function. And so one of the messages we want to get across in this is specifically that. Those therapeutic interventions go on for a long time. So I'm going to end with a couple slides here from, this is what we wear to clinic each day. So these slides are here for a couple reasons. So number one is to remind me to go back to the Transverse Myelitis Association, which is the focal point of what brings us all together here as a community. They host a summer camp for kids and families. Has anyone here been to camp with the TMA? So for those of you who don't know about this, Yes, Doug, you have been to camp, and I have the evidence right there and right there. So this is a camp for kids who have had transverse myelitis, ADEM, NMO, and their families. So they get to come for a little under a week, and it's a fully accessible camp. These kids are in pools, they're on zip lines, they're doing everything no matter what their level of ability or disability is. And it's a time for these families from all over the world. We have had families from China, families from Europe for sure, South Africa, and for these kids, for most of them, it's the first time they ever meet another child who has this condition. And then there's an event called Messy Games. It speaks for itself, where they go around and pelt each other with really awful, disgusting things. So you get your war paint on. So one of the reasons I have this up here is to first recognize the TMA. Second, really show that this is a very unique experience, not just for patients and families, but for the clinicians. The people in this room from the health centers are very passionate and compassionate about not just the care and the science, but being part of a community. And we really do consider ourselves part of a community. And so we bring our whole team. We bring our nurses, our neuropsychologists, our research coordinators, our rehab specialists. I don't know what Doug is anymore, but and we're in there with you getting messy. We're doing it together. And we learn just as much from you as we hope you will learn from us. And we bring our families. These are my daughters, Rebecca and Hannah, and they look forward to getting me messy on a regular basis. And I will say, Dr. Harder's here now. This is actually her makeup. She didn't do this for Messy Games. This is what she wears to clinic each day. But our multidisciplinary team are not just neurologists or rehab specialists. We have neuropsychologists, because we recognize that this condition doesn't just affect your ability to walk, your ability to feel, your ability to pee. This condition affects every aspect of life. These conditions affect every aspect of life. And hopefully what you'll get out of today is a sense of what's coming, what are the options in terms of improving quality of life today, what's going to be in the future, and especially as we get to the breakout sessions, recognizing you have a lot of control, even while waiting for us to get off our rear ends and do more research, you have a lot of control over managing your quality of life today and improving function.